Hello, and welcome to today's webinar, Through the Looking Glass, the Lean ED, the final webinar in the series presented by Lehigh Valley Health Network, Emergenuity, and T-System. Today's webinar will detail how using lean processes improves ED throughput and allows you to create a more efficient ED. My name is Maritza Maldonado, and in just a moment we'll be joined by our presenters. If you have any questions that you would like to submit for the QA period at the end of the webinar, click on the icon with the question mark and type in your question. You can do so at any time throughout the webinar. Feel free to start sending us your questions now. We'll gather these questions and try to address as many as time permits at the end of the session. If we don't get to your question, we will follow up with an email to you one-on-one. We will have a recorded version of the session in the event that you want to go back and review the materials, or if you want to share the presentation with a colleague who was unable to attend. I will distribute the recording of this event to all attendees. Leading our presentation today are Dr. Richard MacKenzie and Dr. David Richardson, practicing ED physicians from Lehigh Valley Health Network. Dr. Richard MacKenzie is an innovative physician, executive experienced in turnaround and management of emergency and ambulatory medicine with multiple sites in university and community settings. Currently co-leads the steering team implementing a unique intake team model for emergency care delivery at the Lehigh-Muhlenberg site. Dr. David Richardson has worked in the Lehigh Valley Health Network and as an emergency physician since 1995. He is currently the Vice Chair Quality, Department of Emergency Medicine, and Chair of the Department of Emergency Medicine PI/QA Committee. We also have a support panel who will assist with the Q&A at the conclusion of the webinar. Dr. John Weary and Chris Kitta of Lehigh Valley and Dr. Todd Warden of Emergenuity. And now to kick off our presentation, Dr. MacKenzie and Dr. Richardson.
Hey, thanks everybody. It's good to be back here, and actually Chris Kitta is going to talk about a couple slides for us today. So welcome, Chris.
Thank you.
Now, last two webinars we talked a lot about the input side of the equation, and there are some of the processes that we reviewed, like full-to-full bedside registration, express care, SuperTrack, vertical flow, and the rapid assessment unit. What we really talked about is how the rapid assessment unit combines all those other processes and allows a larger gain on efficiency. And the empty waiting room is where you want to get to, where you want to be. You want to get those patients in front of the provider as soon as possible, because it's going to improve your patient satisfaction, improve ED core measure compliance, and provide value to your patient.
Wait a minute, Dave. You've just got an upstream flow fix. That's not going to help our downstream.
Well, wait, Rick. I'm going to tell you this again. Hold on your horses. We'll get there. We're going to talk about throughput and output during this presentation. So let's talk about how to make it work and how to make it last. So again, we've shown you how to remove the waiting room queue and how to get patients in front of your physicians and into the treatment area quickly. Now, this may result in another queue in your department. It may highlight the fact there are inefficiencies in your diagnostic study turnaround time. Admitted patients may stay in your ED and board, even when there's a clean and ready bed available up on the floor. We talked a lot about last time about influence and control, and how in the front door of the ED you have a lot more influence and control over what happens there. And for diagnostic study turnaround time and the inpatient units, you have some influence but not a whole lot of control. So we're going to talk about how to make processes work and how to make those processes last. And as you heard before with expensive products, it's not the purchase price that kills you, it's the maintenance. So we're going to talk about how to maintain those processes so it doesn't kill your flow.
All right. Thank you, Dave. We're going to talk a little bit about throughput, output, and some of the interventions or implementations that we have to do to actually get some success on that throughput. So I'm going to frame it up a little bit into 3 Ps. These are the 3 Ps, components of capacity: people, process, and physical environment. These are 3 components that exist in an equilibrium. If you affect one, you will affect the other. So you cannot isolate one. One of the common mistakes many people do is they change the physical space around and don't pay attention to what the impact on process and sometimes even on people really it creates. So you really have to make sure that you control that for those three elements. In fact, it's kind of like a game of whack-a-mole, the old carnival game where you smack one down, the other two pop up. So really, you got to play that game of whack-a-mole pretty well. And that is our capacity. Demand creates work. We don't control demand. It also creates a job. We all have a job that we have to do, and our job is to match that capacity to demand, match those three components of demand. A final kind of P here is the purpose. We have to kiss the intervention's purpose, and I mentioned those in two ways. Keep it simple, and everything you do is an intervention. So you want to build an intervention's purpose simply. There's a Pareto chart, small example of a Pareto chart. You want to rank your problems or your opportunities and attack the biggest one. That's what you want to do as you move forward. Keep it simple. Keep them focused on that purpose. So now, we're going to talk about throughput, and this is my little allusion to insecticides, the DDT, the throughput bugs. So when you really, I'm compartmentalizing a little bit here, but the throughput bugs are really decisions, documentations, and tests. In fact, it could be said lack of decisions, excessive documentations, and excessive and lengthy tests. Those are the throughput bugs. Ideally, I think most of us would love to work in the emergency department and love to be the emergency physician that literally can walk up to every patient and know exactly what's going on with them and make decisions about what needs to happen for their treatment. Now, there are some physicians, there's clearly, as most of the nurses can attest to, there's differences between physicians. Many physicians will order lots of tests and be fairly indecisive. I would guarantee you those are the slowest physicians, and they will slow the flow. So that's what I want to get into, and I'm going to detail each of those as we go through some of the exact processes that will actually help us in this model. And this is almost all process, by the way. So we're trying to advance the slide.
Technical difficulty.
We're having a difficulty with the slide. Well, I'll talk about the slide. So in the next slides, we're talking about the throughput. We're talking about point-of-care testing in terms of there it is. So we're talking about point-of-care testing, 6S, and scribes in this section of the slide. And I'm pointing out with the DDT, I'm giving you kind of a cheat sheet on the side there. Point-of-care testing, this is obviously looking at your ancillary test turnaround time, your blood test mainly. So you want to speed that up. However, there is two caveats to it. One, they're much more expensive, about 5 times more expensive to run a test through a point-of-care testing device versus the laboratory, and their accuracy isn't quite as good. So you've got to be careful and somewhat judicious in your use of them, but they will speed the test. An example we have here is that if we have a GI bleed and you can get a hemoglobin real quick, it can help you stratify where you're going with that patient. You have the 6S. This stands for sort, shine, set in order, and sustain, and safety. So we have all those you can look that up on the web at any time. The big one I want you to remember about that, and a lot of people have made a big deal about the 6S and getting very specific about each one of those things, but really the big point is everything has a place and everything in a place. And that is a key, the everything is emphasized, because if you try and do this part way, it doesn't work. You've got to make sure you identify a place for everything.
And Rick, in terms of efficiency projects, they say a lot of times 6S is one of the first ones to go after because it's easy to involve everybody. It's very visual. You can see exactly what needs to be done and what it looks like when it's done. And then it also kind of paves the way for that sustainment piece to put together a system to sustain it. So a lot of times they say it's one of the first things to go after when you're making any major changes.
Right, and you're combating against the hoarder. So the hoarder that hoards the gloves and puts them, in multiple places around so they can make sure they don't have to walk but 2 feet from a glove. So seriously, you have to put the gloves in a place so that you have enough gloves, but they're going to be in one place and they stay there. Point-of-use storage is a specific version of 6S, and this is where we talk about the room, the actual patient room. We actually make sure that we have everything that is needed at the point of use stored in that room. So the principle is that the nurse never has to leave the room. for anything, or the physician. So everything is there. They can get that patient cared for and get it done quickly. Finally, we talk about scribes. This is obviously paying attention to documentation. It definitely will improve your documentation, oftentimes improving the output or the revenue side of the equation, because the scribes have a clear purpose in mind. Their purpose is made for documentation. On throughput side, probably has a little impact, but not, you need a fair number of scribes to really see that huge throughput aspect of it. So continuing on, we have the electronic medical record, and I put decisions and documentation there. Most people think of it as purely as documentation, but the reality is that there's an entity called distributed cognition. Anytime you write something down, most of us have written notes in college and other things like that when we're taking courses. That's a purpose because it actually processes the information through a different part of the brain. It actually combats what medicine is trying to think about all the time is cognitive error. We do not want to make an error in thinking. So it has a role. If you're not at the bedside with electronic medical record and you're doing a lot of verbal information, moving that patient through, oftentimes you lose that benefit of the distributed cognition and you may make some errors. This is one reason why verbal orders are probably not as good a thing as we think they may be. Finally, protocols and communication systems, these attack them all, decisions, documentation, and testing. Dave, can you say a STEMI response?
Well, you know, Rick, and if you do it in 30 minutes, I think it's faster than the Domino's pizza delivery. So if you match that Domino's delivery, I think you're winning. So that's my joke for a protocol because it is so efficient at most places now. And we can do that elsewhere.
Yes. I mean, you can do a if you can do an MI and move them through the department faster than a sprained ankle, you can do a protocol for everything. So it's got tremendous capability for moving throughput. And I think this is one of the things we really need to spend a lot of time on. Politically, it's not easy to do. Evidence-based is sometimes difficult, but it is a way to get real throughput through your system. And communication systems, this is probably as we become less and less verbal and more and more attached to electronic means, it's very important that we have some way to notify when we have abnormalities or something that needs to be paid attention to. That is probably where a lot of the waste actually occurs. So let's talk about the output. And I'm going to present this in the 3 Ps concept. I'm going to talk about the people, process, and physical space as I describe the interventions for output. There is one caveat and one idea. When we talk about output, I'm speaking specifically about borders and admissions. If you don't have a border problem and you get patients upstairs right away, you've already fixed this. But for many of us and many of the nation, crowding is a big issue, and this is probably the #1 cause of crowding, is borders in the emergency department. So when you talk about the admitted patient, you're really talking about 2 types of patients, or 2 types of impact, where you talk about the availability of the actual bed, so there's a bed actually available, but you also need to talk about the timing of that availability. If they're all available at midnight, it's not going to help you in the emergency department because our peak demand typically is around 10 a.m. to noon, that time frame. So we also have to pay attention to the timing of that availability. And then one idea is simulate. If you're building anything, you want to simulate. And you want to simulate in 2 ways. You can use cardboard cutouts, or you can use an electronic computer simulation. Cardboard cutouts is oftentimes a cheaper method, a much cheaper method, but the computer simulation is probably far more accurate to test out your people, process, and physical space concepts. One key caveat with this, whenever you're building, most architects do not consider the dwell time of those admitted patients and the boarding patients. They consider the volume coming in the door. So, as we move on, we're going to talk about the interventions here. So, for the people, there are hospitalists involved, admission nurse, and bed czar. When you talk about hospitalists, it's getting some mixed reviews in the literature, and many places are slow in the flow. Some places are speeding it up. Admission nurse, same thing, slow in the flow or speeding it up. What this says when you read that in the literature is oftentimes you say it's the process how you're implementing these people. How are they set up? And we'll talk about roles in a minute. Beds are, on the other hand, if you have somebody that has a purpose of finding beds, again, this goes back to the purpose component. If their purpose is to find beds, you're going to have an ally there. So, process. We talk about transition protocol. When I talk about that, I'm talking about the transition to the floor, and that is both nursing and physician. Oftentimes, nurses and having a phone call conversation oftentimes is one of the slower ones, especially if it's phone call conversation and there's a permission component to it. Can I send the patient to the floor? Can I talk to you now? That is oftentimes going to really slow your output. The other side of the equation is the physician ordering. So there are transition admission orders that many institutions have come up with, and they do speed the flow. You've got to be careful that it doesn't slow your flow on your floor so that it becomes very inefficient upstairs. The full capacity protocol, and I put in quotes because that's what it's been called, this is oftentimes, there's a good news about it, is that it is a dynamic variation. It allows you to work off of metrics to say, we're at full capacity, we need to adopt a different system that allows you a variation in flow. The bad thing is if this is happening frequently, you've got a bigger problem, and what you just turned is a bad process called hallway beds in the ED and turned it into a bad process, hallway beds on the floor. It's a bad process no matter what. It doesn't serve our demand. It doesn't serve our patients well. When we talk about inpatient discharge protocol and length of stay reduction, many physicians, emergency physicians, feel that they're not empowered to do that. But oftentimes, if you raise the flag of diversions or hallway beds or anything like that, you may find a seat at the table when they start talking about discharge and length of stay reduction. This is probably the key part. If you can get these done, the discharge protocol earlier in the day, now you got your timing available, length of stay reduction, you get actual beds. And finally, smoothing, and this has been talked about a fair amount. Oftentimes people think about it, you're going to tell a surgeon that he can't operate. Well, it's not that complex or that difficult. It's really about smoothing the inpatient bed needs. So if a surgeon is operating, you can intermingle some outpatients between cases so the inpatient bed needs are not as demanding or coming in batches to the floor. And finally, the physical environment and our 3 Ps. And actually, this is probably the least of the effective solutions because it takes a lot of money to do it. But since you do interact physically with IS components, you need to think about that when you're talking about your physical environment. Where is your IS staying? What does it do? How are you viewing the IS? These are the things you need to think about and how they're utilized. But you really want to have more beds matched to forecasted demand, whether you're talking about ED, inpatient ED, observation, or admission unit. You have to match to forecasted demand. Recognize the ED is an inpatient buffer, whether you have a good flow or not, unless they spend 0 minutes in the emergency department on the way to the floor, you've got a buffer there. So they're sitting there waiting, and typically what happens in many hospitals, that mid-part of the day, you have a bunch of inpatients sitting in your emergency department, buffering so they can get the inpatients discharged from the floor. Finally, I'm going to mention this admission unit, a rapid admission unit, express admission unit, it's called in various places. That does have some value in the sense that it can operate like an ED and actually offload some of the direct admits, but also, you can also think about this as flexible space. We actually use our pre-admission testing area here as flexible space at 2 p.m. We actually used it for a period of time when we needed it and actually allowed us to offload some of the admissions at 2 p.m. so we get some more space in our emergency department. We offloaded our inpatient buffer, and they became a friendly buffer for us. So we're going to make it last. We're going to move on to make it last. That's the throughput and output, kind of quick, down and dirty. But make it last. This is the thing, as Dave alluded to. If you can't pay for the upkeep, it's going to fail. It's going to fail. So you really have to get it last. Really, you need leader support. And the leader support comes in multiple ways, but it's really about demand and capacity management through following some metrics and dashboards, and they have to forecast the growth. So you have to have them commit to all 3 of those components as they go through the system. And I mean commit, not words. They have to be involved. They have to be involved in the metrics and following the metrics and following dashboards. Certainly teamwork. It's oftentimes mentioned, but it's not managed. You really have to manage that teamwork and make sure people are following through with teamwork and teach to it. Certainly improving flow. Online coaching, I will talk about in specific. This is very important, I think, in emergency medicine and probably underrated and probably under-implemented, actually. The reality is the PowerPoint slideshow for a 24/7 operation that deals with life and death decisions probably is not going to work for teaching people new process, new people, new physical space. It's probably not going to work. What you really need is somebody standing at their elbow or at least available in the department for when this happens, what do I do? That's what online coaching is about. So just remember, when this happens, what do I do? So I'm going to turn it over to our 8 ways kind of guy. Oh, no, leader support. So we're going to talk about leader support. I already talked about it. The one thing is you want to do it right the first time, and you want to be vocal and visible. Sometimes if you do that PowerPoint presentation, you don't get out there, you don't do the online coaching, you're not going to be vocal, you're not going to be visible, and if you just sit back in a room and do a PowerPoint, it's not going to be stick at that time.
And Rick, just some of the observations with some of the things we've done here is just that visibility. Early on, you'll often see that, okay, let's give it a shot, and then it may fall by the wayside. A couple weeks, it's just going to go away, another flavor of the month, and we'll pick up something new. And I think what's real important is to have that leadership visibility, steady, over time, consistent, just to kind of keep that message alive through their visibility on the floor that this isn't going away, this is the new process, and we're going to stick to it.
And I would give you one red flag if you're the leader and you do a presentation as a PowerPoint and say this is the way we're going to change your world, and you get no resistance, they don't believe you. So you need to, if you have that red flag, that's a bad thing. On the other hand, if you get a ton of resistance, that's good. They believe that you're going to change their world.
Hey.
So now to the waste guy.
Well, Rick, you talked about point-of-use storage, and that's one of my passions. And as you decide what to fix in your emergency department, what projects are you going to do first, and how can you make your emergency department the best place to work and remove waste in your system? And when you think about improving efficiency, you got to start with the 8 ways in healthcare. And my favorite is unnecessary motions. And there's a picture here of the blood draw drawer from our point-of-use storage tower. And when I was working in the ED, I needed to place some stitches, and I had to go to several places to get the stuff I needed to sew up a laceration that was 2 centimeters long. And it took me more time to find the stuff I needed than it actually took to suture up this laceration. And so some places may not have that. They may have this fixed. But I looked around and I noticed the nurses were doing the same thing. They were leaving the patient bedside to obtain supplies to complete their tasks that they did on almost every patient. So over and over again, they would leave the room. And I said, boy, that's unnecessary motion. So that's one of the 8 ways in healthcare, and it turned out to be significant. We actually took a look at this and studied it, and it was a significant amount of time. So point-of-use storage was our solution. We actually addressed all 8 ways using this point-of-use storage methodology. Now, as you do your waste walks, you go around and look how people are working, and you hear what they're saying as to how much time they waste doing certain things, then use the 8 ways to help you define those. Because some people may feel that it's normal for them to walk out of the room to go get something because it's what they do as their standard work and don't realize it's wasteful. The planning and stakeholders in tabletop. I'm just going to talk a little bit about this. There's many books and articles out there that you can read about change management, developing and implementing a new process. And we don't have time really here to discuss project development here. What I will say is that a change process is only successful in the long run, and let me repeat this, it's only successful in the long run if the stakeholders truly adopt and sustain the change. So process and technology change cannot be implemented without a change in the hearts, the souls, the behaviors of the people involved in or are impacted by the change. True adoption and sustainability of change requires thoughtful planning and focus. Stakeholder planning begins at the earliest phases of any initiative, and as project objectives and scope are identified, stakeholders naturally emerge in various categories. These categories can be leaders and managers, project team members, project sponsor, patients, impacted employees, support partners like human resources, finance, testing, operations. And so all those people are your stakeholders, and you have to identify them and get them involved. This image here shows a tabletop exercise with nurses, physicians, and tech partners. And they have actual patient charts they used as scenarios for movement of patients through our rapid assessment unit, radiology, main emergency department into an inpatient bed. There was team engagement, creativity, and a beginning in the change in the hearts and souls of the people involved.
And I think one thing to add here, too, is as early on in the planning process as you possibly can. So Rick talked a little bit about coaching, online coaching as the best model. And I have to confess, I came from industry a couple of years ago, and whenever we implemented or started on any major change initiative, we would shut down the line and get everybody in one room, and everybody heard the same message from the same person at the same time. Well, as I learned quickly in healthcare, that doesn't happen. The ED is not going to shut down. So you're not going to be able to train all staff in one sitting with one message at one time. So often I hear, what's the next best method? Well, let's train via e-learning. Let's throw it on e-learning. Everybody will hear it, and they'll all come in on Monday morning, and everybody will do the process the exact way it's supposed to be done. Well, that doesn't happen either. So let's give it a shot on email. And that works to a point, but again, that's not going to really help towards sustainability. So as Rick said, online coaching is by far the best method. What do I need to do when? And if I'm not doing it, is there someone there to kind of redirect me? And we found with some of our change initiatives that it works very well, and it has to be consistent. It's not just one day, you're in, you're out. It has to be over a period of time until the observable behaviors are sustained.
And the coaches are oftentimes people with titles and people without titles, champions of the process. So you don't have to hire people to do this. And you don't have to have legions of people to do it. Oh, the defined roles. This is I'm just going to talk briefly. This is an example of a flow chart here. Really want to define your roles and build people like stepwise progressions of how they take care of that patient. And we have different people. This is our intermediate disposition RN and our acute care RN, and it shows what they're supposed to do differently. So it's a very clear idea with it.
And this goes back to one of the main tenets of lean standard work. And standard work is another word for expectations. What are the expectations of this role? And I think what we found, and I'm sure you'll find this as well, unless it's specifically stated, it's going to morph into all kinds of other, well, maybe I do this, sometimes I do this. So the more standard work you can have explicit to what those roles are, the better chance for sustainability.
And staffing principles, sort of a little offshoot, and making sure that you have the appropriate staff prior to your patients arriving in the emergency department. So this was sort of a little offshoot that we wanted to throw in, is staff based on your demand, staff prior to that demand arriving, and maintain your doctor-to-nurse ratio so there's not a conflict where you have 5 nurses waiting for one physician, or you have one physician and only 1.5 nurses for that physician, and you're going to have a mismatch. So you're going to have too much work for one provider or another. And that care team concept is also in the literature to improve flow through your emergency department, where you have 10 beds or 12 beds and they have 3 nurses and 1 physician, and they work as a team in that area, so you don't have one physician working with 30 nurses or 20 nurses, depending on how big your ED is, and can't find that person. So it sort of compartmentalizes things a little bit, and then you get that team concept. Everybody's working together in that area to move patients through the system.
So we didn't really talk about one of the biggest components of implementing any change and sustaining it, and that's measurement. And we could actually do a whole separate webinar on just measurement itself. But we use a tool here, it's called visibility walls. But even before I discuss the setup of visibility walls, look on the upper left-hand side of the slide, and it's really about alignment. And this is where that leader support comes in. You have to make sure you're aligned with leadership. If you look on the far right, or the under alignment, you'll see maybe 10 to 12 boxes there. That's the front line. That's the director level, ED level, inpatient level. That rolls up to, say, the administrative level, that middle management level, which rolls up to the VP or executive level. So you have to make sure the metrics that you're measuring at the floor level are aligned with the VP or senior executive level goals. Oftentimes what we'll find is the directors believe something is important and they're measuring that, and the VP or the executives, it's not on their goals, or it's not even on their radar. So there's a mismatch there, a misalignment. The tool that we use is, if you look under transparency on the bottom right of the slide, we use visibility walls. Those are our monthly snapshots of what we're trying to measure. And obviously the common ones in the ED, left without being seen, diversions, door-to-dock time. So we set that up, the visibility wall. The structure of that is based on our fundamental priorities. You see S, Q, C, service, quality, and cost. Growth is another one which doesn't happen to be up there. But this is our monthly snapshot of how are we moving those needles. Are we doing better? Are we doing worse? But when you think about that, if you implement any kind of countermeasure and you tell your staff, well, we're going to do these actions, and then, by the way, we got to wait 31 days until we can look to see how we're doing, there's not a whole lot of buy-in there. So we actually take it down to the next level, down to the floor level, and that's called daily management. Measure the daily actions that move the monthly needles. And we use some of the T-System reports to do that. And behind the gentleman's head there with his hands in the air, you'll see that's our daily management board. And one of the measurements that we're doing is door-to-dock time. Every morning, the charge nurse will print out from the T-System reports what our door-to-dock time was for the previous day. And a huddle, a daily huddle, is part of that daily management system. They talk about it at the huddles. What happened yesterday? What can we affect? What's out of our control? But the idea is to make it manageable, make it measurable, and make it visible.
So the lessons learned. This is what we hope you've learned today. There's people, process, and physical environment. You got to pay attention to the human factor. You got to match things. You got to actually process, form follows function. So you want to make sure you have people, process, and physical environment all aligned with your purpose, whether you measure it or not. So we're open for questions.
All right. Anyone else have any questions? I did have one just come through. All right. How do you get leadership support for the types of solutions you discuss?
Oftentimes, the one thing that often works with that is actually saying yes. And it's a difficult thing for a lot of people to do, but if they come up to you and say, you have a problem in your emergency department, and you say yes, and they say, well, you're not getting the patients upstairs fast enough, and you go say yes, and then they say, okay, you're going to fix it? Yes. And then you say, give me data. Let me figure out how to do it. I need people to support me. I need some interventions here. So oftentimes, the worst thing you can do is say, no, not my problem, because then somebody else will take care of it, and they may not take care of it well. So it's a paradoxical part, but that's where you can get leader support.
Another part, too, or another way to look at it is, I say bite it off in small chunks. In other words, you're not going to fix the entire thing all at once. Can we do a rapid cycle test or a rapid improvement event just to test fixing a portion of it? And it may not be perfect, but you may actually learn something to help you bite off a bigger chunk next time.
One of the things you also find when you do data on this, and for those of you, you're familiar with the bell-shaped curve when we talk about laboratory tests and other things like that. Really in flow in the emergency department, it's always a kind of a slurred bell or a broken bell. So the tail, the long tail out there drives perception. So if you have people coming up to you and saying there's a real bad problem, and your average numbers tell you one thing, and they're telling you it's a bad problem, you probably do have a bad problem, but it's just happening less frequently.
Okay. Great, thank you. Next question. Who does your real-time coaching with the frontline staff?
It depends. We have, for the physicians, I think what works best is the physician online coaching. You know, the credibility, I think that works the best. With nursing, we have peer-to-peer works best as well, nurse to nurse. We have lean coaches that will jump in and do that. For that leader support and visibility, we actually have different themes that we try to get different leaders from different functions. For example, we'll have the registration director come in and actually do some coaching for the registrars and maybe ask some questions of nursing regarding the process. They'll look at that standard work process role and they'll say, oh, I noticed this. And that helps the coach as well. So peer-to-peer, lean coaches, and then other leaders to process involved people as well.
We actually have, we're scheduling a calendar where we have one person for Monday, one person for Tuesday, one person, and these are all managers within the system at this point that have some stake in this place. So we're trying to match them. We don't do Saturday and Sunday, but we're trying to match it per week, and then we're having a theme per week.
And it really goes back to that leadership involvement question. So that leadership support question, too, is that the leaders are visible, and so they come through and do some coaching and ask, how are things going? So their involvement is visible and seen and known.
And I think the cross-functionality here, it's a lot of work and it's a lot of effort, but I think it's kind of money in the bank to make sure that all the departments that touch the process are involved and they have a stake in it to help for that sustainability piece.
And once again you change the hearts and minds of those frontline staff and they're convinced that this will stay and that the changes you made are beneficial to not only them but to their patients, so they see value across the board and it makes their day easier, then that sustainability comes with that. And so this is that road to sustainability.
Okay, great. The next question that was submitted, what T-System reports do you use for the visibility wall information?
Oh, that's a good one. We actually use a fair number of them. I can't tell you, I don't have the exact title letter. You do?
Yeah.
All right, go ahead.
The one is door-to-dock time, and what we do, that's not a blanket. Because we have the rapid assessment unit, we have the main ED in the back, we don't want to skew one with the other. So we can actually separate for just the rapid assessment unit and just for walk-in discharge patients, and we get that from T-Systems at 7 a.m. the following morning for the previous 24 hours. So that's one. And I think that's actually A07 under the T-System menu. I've been too close to this for too long. Another one we do is patients waiting greater than 2 hours to be seen, and I think our percentage is 0.05%, but the idea is we want to see those outliers to see is there anything process-wise we can work on there.
Actually, we use that, and the T-System report actually identifies that particular patient, and then we can look back at the chart and see what happened with that patient. And identify if there's any opportunities for systems improvement.
Another one we'll look at is unlocked charts. I think there's a drop-down menu of, 20-some different reports.
Right. But and you can look at productivity and kind of look at how the system is working. You can look at productivity by disposition code. So we can look at how our hospitalist throughput is doing. So it can give us real-time feedback next day. We can get next day as opposed to waiting for a week or so for any kind of our other metric maneuver here.
Right, and again, that is so helpful. Rather than waiting a month to see how your countermeasures worked, you can get real time, within 24 hours, you can get some kind of idea, did those daily actions move those needles?
And the information, too, is very good looking at individual providers and did they meet their metrics for door-to-provider time? Are they seeing the number of patients we expect them to see in our rapid assessment unit, because that's dependent because of the huge variability in patient arrivals hour to hour. We want to meet that metric of seeing the patient as soon as possible within 5 minutes. We can see if one provider is only seeing 10 patients in an 8-hour time frame and another one seeing 24, we have to figure out why that's happening.
And so I would recommend anybody that is looking at metrics to look at those T reports. And I think they're very valuable, and see what works for you.
Right. This next question, they started with a comment. Thank you for lots of excellent ideas and suggestions, but where do you suggest we focus our efforts first? Your worst place.
So that's where you focus your efforts. You want to define, and sometimes it may, you may not totally be apparent what that worst place is. There's something you can, what they call a Delphi method, which is basically just a method for surveying people. You can sit there and here's the 10 items that we think we need to work on. And you can actually survey your staff, get that staff involvement, and actually ask them, what do you think we need to work on? and then that becomes what you work on first.
And another, and you're going to laugh at the simplicity of this, another method is just go sit out in the waiting room. Go sit in the ED and just watch. Just stay at one place for 45 minutes to an hour and just watch. And a lot of times it'll surface right before your eyes, and you'll know exactly where you need to go.
The other thing you might hear from other people, and this is a kind of a lean concept, work on the downstream processes first, then move upstream. That's the classic teaching, but you may lose your staff support if you don't ignore what they see as a problem. So you got to engage your staff with that.
And back to what Dave said before too, 6S is always a great place to start. I'd be hard pressed to find an ED where almost all staff said that we have all the supplies right where we need them all the time. And I think you get a lot of buy-in with that right away because it seems to be a chronic problem wherever you go.
However, the big one in 6S is sustain.
Yep.
If you say the glove boxes are on this corner, you need to ensure that they don't pick them up and move them. So you have to sustain that, and that's not easy to do. So the first part about doing the exercise to get the 6S, really good, but you really have to pay attention to that online coaching and sustaining that 24/7. Your night shift and your weekend shift can destroy a 6S real quick.
Great. Any more questions? Looks like that's all that have come through. Anyone else have any additional questions at this time? We'll give you just a minute or so to see if anyone types anything up.
Well, thank you, guys.
All right. We'd like to go ahead and thank everybody for attending today's session. This concludes today's webinar in the series of webinars presented by Lehigh Valley Health Network, Emergenuity, and T-System. Again, we will get the webinar recording and presentation out to you tomorrow. And if you do have any additional questions, go ahead and shoot them our way, and we'll get those answered for you. Thank you, everybody, for your time.
Thank you.
Bye-bye.
Bye.